Hello, my name is Robert Zeiser. I am the director of the Division of Tumor Immunology at Freiburg University Medical Center. Today, I will discuss the question, how could an understanding of non-classical acute graft-versus-host disease organ involvement improve clinical practice and patient outcomes? The classical target organs of acute graft-versus-host disease include the intestines, the liver, and the skin. The damage of these organs is relatively easy to detect for the clinician as diarrhea, increased bilirubin, and rash. However, there is increasing evidence that also other organs are a target of acute GvHD, where the damage is less apparent or more difficult to distinguish from drug toxicity. And those organs include, beside others, the central nervous system, the lungs, the ovaries and testes, the thymus, the bone marrow, and the kidney. One of the non-classical organs and GvHD target organs that is considered to be sterile is the central nervous system. However, it was shown in mice transplanted without post-transplant immunosuppression that the mice developing GvHD also display impaired neurocognitive function, including exploratory activity, spatial learning, and memory. When these mice were investigated by histological analysis, it was found that infiltration of effector memory T cells in the brain were detectable together with apoptotic cell death of neurons, which were probably responsible for the impaired neurocognitive function. Not only T cells, but also microglia was involved as a selective genetic ablation of TGF-beta activated kinase 1, TAC1 in microglia reduced central nervous system GvHD. Now, the question is, how could an understanding of non-classical acute GvHD organ involvement improve clinical practice and patient outcome? So some patients may have no signs of intestinal, liver, or skin GvHD, but have neurological deficits that is not explained by infection or toxicity or viral events. In such patients, the search for CNS GvHD may be helpful and improve patient outcome. Also, the kidney can be selectively affected and may benefit from GvHD treatment. Additionally, non-classical GvHD target organs may be included into the GvHD grading system in the future when more data on their involvement is available. A better understanding of the involvement of the thymus and lymph nodes in acute GvHD could help to develop new strategies to reduce immunodeficiency after allogenic hematopoietic stem cell transplantation, for example, by reducing regenerative approaches, including KGF or IL-7. Lung GvHD is a major complication after allogenic stem cell transplantation that is connected to a high mortality. Reducing this non-classical manifestation of acute GvHD could help to decrease the incidence of chronic lung GvHD, as acute GvHD is a major risk factor for later chronic GvHD. Regular lung function testing at defined time points after transplant can help to detect pulmonary impairment early and to increase immunosuppression after excluding infectious causes. Therefore, the investigation of the non-classical target organ lung for GvHD manifestations may help to improve patient outcome. The reports on acute GvHD affecting the bone marrow and thereby hematopoietic function are clinically relevant, as poor graft function and failure are major clinical challenges that we often face in our transplanted patients. The observation that donor T cells infiltrate in the bone marrow where they damage different types of stroma cells support the use of immunosuppression in patients with poor engraftment and evidence of acute GvHD. With that, I'm at the end of my presentation. I hope you enjoyed it and looking forward to the next presentation. Thank you very much.